following podcast is part of a certified educational activity titled A Renewed Look at MRA Therapy, Improving Renal Outcomes and Reducing Risks in Patients with Type 2 Diabetes. Access the entire activity and complete the post-test at peerview.com/JNH860. Downloadable slides and practice aids are also available.
Hello, this is Rajiv Agarwal from Indiana University School of Medicine in Indianapolis, Indiana. Welcome to this educational activity focused on improving renal outcomes and reducing risks in patients with type 2 diabetes. Included as part of this activity, I'll be showing you how to use some practice aids that you can download with the hopes of helping you address clinical challenges that you may encounter in your clinical practice, or that may support some of the discussions you may already be having with your patients. So let's get started. The current approaches to identifying and managing patients with diabetic kidney disease. Diabetes is the leading cause of chronic kidney disease and end-stage kidney disease in the United States. Reducing the incidence of end-stage kidney disease by 25% by 2030 is a national healthcare priority. The 10-year risk of mortality for individuals with type 2 diabetes and CKD is elevated, and CV death is the primary cause. In fact, studies show that the 10-year cardiovascular mortality in patients type 2 diabetes and CKD is about 20%. That's worse than many forms of cancers. Some medications can reduce the rate of CKD progression and cardiovascular death in individuals with type 2 diabetes, but they are significantly underutilized. So how do we implement a framework for CKD screening, risk stratification, treatment, and education? What's our plan? The first is to determine the individual or a population level risk. Of course, when you're seeing a patient in your clinic, you want to determine the individual level risk. And that can be done by CKD screening for risk stratification. How often should we screen patients with diabetes? What tests should we do is what we're going to consider next. So let's take a help of our patient, a 68-year-old African-American man who presents to your clinic with a past history of hypertension for 22 years, dyslipidemia for 15 years. Patient has had coronary artery disease, 2 stents placed 14 years ago, type 2 diabetes for 10 years, CKD for 7 years. And on exam, his abdomen is benign. He has 1+ pitting pedal edema. BMI is elevated at 33. His LDL cholesterol is normal. A1C is within normal limits. And the patient is on atorvastatin 80 milligrams once a day, metoprolol extended release, olmesartan, and linagliptin. Blood pressure is high at 138/76, and he has got a 4th heart sound, no S3. GFR is depressed at 57. USCR is elevated at 494. Serum creatinine is 1.6, BUN 37, and serum potassium 4.5. So let us consider what got this patient in this state. First of all, the patient has diabetes, and initially, many years ago, the patient's GFR was probably high, and then it became normal, and then it started falling. But before it started falling, there was probably the occurrence of microalbuminuria, or what we call as moderate albuminuria, and then it progresses to very high albuminuria. This patient now has very high albuminuria. If we did biopsies of patients who have significant duration of diabetes, what we find is presence of injury to the kidney even before albuminuria has its onset. You can see basement membrane thickening, mesangial expansion, cellular injury, and oftentimes patients have hypertension, which probably can be best identified in these patients with ambulatory blood pressure monitoring, and often patients have an increase in nocturnal blood pressure even before some of the other manifestations take hold. As the disease progresses, these patients get cardiovascular disease. This patient has a significant physical exam. He has got a 4th heart sound suggesting that the ventricular diastolic function might be impaired, and therefore he might have diastolic dysfunction, left ventricular hypertrophy. And this is soon followed by kidney complications, for example, kidney failure and the need for dialysis. Traditionally, in this patient, we would interpret the GFR as being slightly impaired, as 57 is almost normal, but is this the whole story? So tell me what you think. Does this patient have CKD? Well, it turns out that if we only measured GFR in this patient, we really didn't assess the kidney function completely. The current ADA guidelines say that in patients who have type 2 diabetes, we should measure urinary albumin at least annually, and estimated GFR should be assessed in all patients type 1 diabetes who have a duration of diabetes for at least 5 years, and in every patient with type 2 diabetes, regardless of the treatment duration. Because what we know in people with type 2 diabetes is their disease might have had its onset decades before, starting with insulin resistance, pre-diabetes, and culminating into kidney injury unbeknownst to the patient before the patient manifests as a patient with type 2 diabetes. So patients with diabetes and urine albumin more than 300 milligram per gram creatinine and or estimated GFR 30 to 60 should be monitored twice annually to guide therapy. So in this patient, the patient has both criteria, has a UACR of more than 300 and the eGFR is 57. So this patient should at least be seen twice annually, and both these tests are to be monitored on a frequent basis. Now, why does it make a difference? Why should we be looking at albuminuria? Why? Because it's a huge risk marker. As you can see on this slide, we have people with type 2 diabetes and albuminuria, and the risk for all-cause mortality in the subsequent 10 years is almost 1 in 2. 10-year all-cause mortality 1 in 2. I was just speaking to cardiovascular mortality of 20%, but you look at all-cause mortality, half the patients are dead in next 10 years if they have both impairment of kidney function and albuminuria. That's a very sobering statistic. And as nephrologists, we have learned that the assessment of kidney disease in any patient with type 2 diabetes is incomplete if we only measure eGFR. If we measure eGFR and albuminuria together, we can better stratify the risk, and that is shown in this KDIGO heat map. If we don't do this, we basically are missing an opportunity to better stratify risk. For example, in people who have a GFR of say 57 and you haven't assessed UACR, you might consider them as moderate risk. But if they have a UACR of very high, like in this patient, 494, the patient is at very high risk of future kidney failure, future cardiovascular disease, future cardiovascular mortality, and even acute kidney injury. It's a marker for all these risks in any patient who has both an impairment of kidney function and UACR. Therefore, it is really important to screen these patients initially, and in this patient, we should be calling this patient twice a year and measuring it frequently, make sure that we have a good handle of it. So let's go back and ask the question. We now have assessed the risk. How should we stratify the risk? Now, we have information in this patient where if we were just measuring UACR or eGFR alone, we would have an incomplete picture. Turns out that 95% of the patients who have type 2 diabetes have information on eGFR, but only about half the patients have information on UACR. So UACR significantly adds to the risk profiling. For example, in this patient who has stage 3A kidney disease, if we didn't measure albuminuria, the patient could have either moderate, high, or very high kidney failure risk in the future. But because we have assessed UACR, we can clearly define that the kidney failure risk is extremely elevated. So let's go back to the practice tool and identify that this patient can be risk stratified using both eGFR and UACR together. Now, this practice tool was inspired by the KDIGO guidelines. It's not something that we are coming up front ourselves, but because everybody has come up with a lot of good information on the bivariate assessment of kidney failure risk through the assessment of eGFR and UACR, we can risk stratify this patient. Now, in this patient has UACR that is elevated and eGFR that is depressed. And the KDIGO guidelines suggest that we monitor these two values twice a year. So the practice tool helps you remind you that we need to do this twice a year, but also helps the patient understand that the risk is elevated and we have treatments that might reduce the risk, and that's what we're going to discuss in the next part. So now we have risk stratified the patient. We know that the patient is at high risk for kidney disease progression, but we have come a long way in the last 20 years. In the last 20 years, all we knew was control blood pressure, glycemia, quit smoking, weight loss, and then ACE and ARB. That's it. But what are the treatment options today? Have things changed that can reduce the risk for kidney failure progression and cardiovascular disease in this patient that we are seeing today? So the current therapy on this patient today is a good dose of statin, high dose atorvastatin, 80 milligrams. The patient is on an ARB, olmesartan, in a reasonable dose. Metoprolol is there, but linagliptin is there, but the blood pressure is still elevated. And we have some treatment opportunities in this patient. And the question is, would you make any changes to the medication regimen given what you know about this patient today? So we have several options. And what guidelines tell us is that we have multiple pillars of treatment. So these traditional pillars used to be risk factor management, which was based on glycemia control, weight loss, blood pressure control, lipids, reduction in sodium intake, smoking cessation, physical activity, protein restriction. These were things that before we discovered that ACE-ARBs are useful. The first trial was done in 1993 with captopril. In 2001, we had a back-to-back discoveries of irbesartan and losartan for abrogation of progression of kidney disease in patients with type 2 diabetes, but those were the only pillars of treatment. Subsequently, we discovered that what we have with RAS inhibitors is more than blood pressure control. We know that they work at many different sites of nephrons, including reducing sodium reabsorption, improving the efferent arteriolar tone, improving the blood flow, but we kind of stopped there. The main problem with the RAS inhibitor use was hyperkalemia, because patients got hyperkalemic as kidney disease progressed, and when we were using an ACE or an ARB, that further increased the risk for hyperkalemia. But when we stopped the RAS-C, it increased the risk of all-cause mortality, CV mortality, and the risk for dialysis initiation. Now, this information is relatively new, where observational studies suggest that stopping these medications is potentially harmful to the patients. So we monitor potassium levels, and the KDIGO diabetes guidelines suggest that we monitor potassium within 2 to 4 weeks after starting or changing the dose of any ACE or ARB. If the patient has normal kalemia and there's a less than 30% increase in creatinine, then they recommend that we increase the dose. With hyperkalemia, we review concurrent drug therapy, consider diuretics, bicarbonate, or GI cation exchangers. And if the patient has an increase in creatinine, then we consider things like correct volume depletion, stop NSAIDs, reduce the diuretics, and consider renal artery stenosis. So it's not the simplest thing to do. It's kind of complicated. But over the last few years, we have expanded our armamentarium of kidney disease treatments from 2 pillars, which was simply based on risk factor management and ACE and ARBs. We at least have gone to 4 pillars, which include SGLT2 inhibitors and the nonsteroidal MRA, Phenerone. The SGLT2 inhibitors have been based on 2 very large trials, Credence and DAPA-CKD, and we also have EMPA-Kidney recently stopped, and that should be announced fairly soon. Phenerone likewise is based on 2 large programs, FIDELIO and FIGARO, encompassing more than 13,000 patients, which show that the drug Phenerone reduces the rate of kidney disease progression and also reduces the rate of cardiovascular disease onset in these patients. GLP-1 RAs is something that we are studying right now in the FLOW trial, and the FLOW trial should be announced in a couple of years. What we know for sure with the GLP-1 RAs is that they reduce albuminuria. They also seem to be protective against the atherosclerotic cardiovascular events, and if they produce improvement in atherosclerotic cardiovascular events, and that translates into net clinical benefit in terms of myocardial infarctions and strokes and kidney failure progression, that would be the 5th pillar that can potentially be a very strong pillar in addition to the previous 4 pillars that we are talking about. The problem is that most people are not on the 3rd and the 4th pillar. They're relatively new, and that's what is important to recognize, that despite the use of RAS inhibitors, the renin-angiotensin system inhibitors, which is basically ACE and ARBs, we haven't reduced the risk of inflammation and fibrosis, and what we are learning is ACE and ARBs may not be enough. In fact, ACE and ARBs are not enough even in combination therapies. We did multiple trials like ALISCA and Altitude trial, like the VA-Nephron trial, where we combined an ACE and an ARB, and we found that the combination was really not effective in reducing hard outcomes. However, when we block the final common pathway, which is the mineralocorticoid receptor, through an antagonist, a nonsteroidal antagonist with Phenerone, we can actually reduce the rate of progression of kidney disease. So let's come back to our patient, and we say, okay, the patient was switched to diltiazem from metoprolol and was placed on an SGLT2 inhibitor. He comes back, his blood pressure remains high, his heart rate is within normal limits, he still has a high BMI. The GFR has dropped slightly, his UACR is better, but the question is, what do we do next? Well, it turns out that we can consider 3 options: spironolactone, eplerenone, and Phenerone. And I think the best source of information on how to use a drug is the package insert. The package insert for spironolactone tells you the indications, which is the use of this drug in hypertension, heart failure with reduced ejection fraction, where it is a class 1A indication, in patients with refractory ascites, nephrotic syndrome, and primary hyperaldosteronism. Eplerenone is a drug that came after spironolactone, and it's approved for post-myocardial infarction, myocardial dysfunction, HFrEF, and in patients with hypertension. Phenerone is indicated for none of these indications. So it's not indicated for hypertension or HFrEF, etc., but it's really indicated to reduce the risk of sustained eGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and hospitalized heart failure in patients with type 2 diabetes and CKD. So you can see there's really no overlap in the indications for the new drug, nonsteroidal MRA, and the older drugs, spironolactone and eplerenone. There are differences among these drugs in the sense that, of course, they are chemically different, and their potency for spironolactone is high, as is Phenerone. Eplerenone is slightly weaker. But phenerone is quite highly selective to the mineralocorticoid receptor, so it doesn't have androgenic, anti-androgenic side effects like gynecomastia and impotence. Metabolites are quite a few with spironolactone. Eplerenone doesn't have that effect, and phenerone has no active metabolites. The tissue distribution is quite remarkable. Spironolactone is highly concentrated in the kidney, as is eplerenone, whereas phenerone is kind of balanced in both kidneys and the heart. Now let's talk about these two trials, FIGARO and FIDELIO. FIGARO was done predominantly to reduce the rate of progression of cardiovascular disease in people with type 2 diabetes and CKD, and FIDELIO was to look at the progression of kidney disease in people with type 2 diabetes and CKD. And they were kind of complementary trials. They were done at similar sites, more than 1,000 sites, 13,000 plus patients. And the patients that were recruited all had GFR more than 25. All of them had albuminuria, and all of them were on maximally tolerated labeled dose of ASO-ARB, which is, as I told you, second pillar after the lifestyle modifications. But the patients were excluded if they had HFrEF. For that, spironolactone is a class 1A indication, and you don't want those patients in a clinical trial. And these patients, 13,000 plus patients, were randomized to either phenerone or placebo in equal numbers and followed for a median of 3 years. And they were on pretty effective therapies. They were a population of 65 years age on average. 70% were men. RAS inhibitors in all the patients, 3/4 on statins, A1C 7.7, blood pressure very much similar to the patient that we saw today, 137/76. And the prior history of heart failure was limited to 7.7% of the patients. Now, it turns out that most of the patients had impaired GFR, but 40% of the patients had GFR more than 60. So unless you measured UACR, you would only identify 60% of the patients in the fidelity analysis because these patients would be missed. You won't even know that these patients are at a high risk for kidney disease progression and cardiovascular disease. The median UACR was 515, and nearly a third of them had microalbuminuria. 2/3, of course, had macroalbuminuria. Now, the results were quite remarkable. If you look at the composite results of an individual level pooled analysis, we find that the cardiovascular endpoint was reduced 14%, as was the kidney composite by 23%. The kidney composite that we are talking about is what the endpoints were used traditionally in the captopril trial, IDNT, Renal, Credence. That's based on doubling of serum creatinine, end-stage renal disease, or receipt of dialysis or transplantation, or death from kidney failure. So we are using the same endpoint, and we're finding on top of ACE and ARBs, it reduced the risk by 23%, which means that the drug is working on top of, and that's what is making it a pillar. Now, for the patient, it's quite simple to explain. The way I explain to the patient is that if you take this drug, we reduce your risk for heart failure by about a fifth and going on dialysis by about a fifth. It's an approximation. You have a 22% risk reduction for heart failure hospitalization and 20% reduction for dialysis. And on top of standard of care, phenerone reduced the risk of clinically meaningful cardiovascular and kidney outcomes in patients with type 2 diabetes over a broad spectrum of chronic kidney disease. Remember, there's no upper limit of GFR. Everybody had a GFR of more than 25. The caveat is that we want to use this in patients who have a potassium of 5 or less. Can't use it in people with hyperkalemia. Why? Because the major risk that this drug poses is hyperkalemia. It doubles the risk approximately from about 6% to 12%. And these are people who are experiencing potassium, which is elevated anytime in the trial. It's no surprise that hyperkalemia is elevated. Two other risks that you should be aware of is hypotension and hyponatremia. These are labeled risks in the package insert. And we should be aware that if somebody has hypotension, it could be because of phenerone. So it turns out that FIDELIO, FIGARO are broadly generalizable. in the US population has fewer individuals with severe albuminuria and people with a lot of moderate albuminuria and type 2 diabetes. And if we didn't screen for these markers, the opportunity to reduce the increase in cardiovascular risk would not it would be lost. So it's important to consider that these patients ought to be treated with this drug. Now, how do we dose phenerone? It's fairly simple. If the patient has GFR more than 60, start with 20 milligrams once a day. If they have less than 60 GFR, then you start with 10 milligrams. If it's less than 25, not recommended. You don't want to use the drug. So 10 milligrams if you have less than 60, 20 milligrams more than 60. Now, if you call the patient back, we just need to call them 4 weeks after starting the drug. And 4 weeks after starting the drug, you have a potassium of less than 4.8, you can increase the dose to 20. If they're on 4.8 to 5.5, you maintain. A lot of people think that, oh, potassium more than 5, we ought to stop the drug. No, you keep going unless the potassium is more than 5.5, in which case you withhold the drug and you call the patient back. And if the potassium is less than 4.8, we can start the drug again. I think it's less than 5, you can start the drug again. That's what the package insert says. So it's very important that we don't stop the drug and label it as allergy, because the more we can expose the MR antagonist on top of other drugs, the greater the risk reduction the patients can achieve. So we decided to add phenerone to this patient's regimen. And what should the initial dose be in this individual? Well, clearly, the GFR is 45, it's less than 60, so we have to have the patient on 10 milligrams. And you have to call the patient back in 4 weeks, not in 2 weeks, not in 1 week, but you call the patient back in 4 weeks. We have done these studies, we have called them more frequently in phase 2 programs. It doesn't really reduce the chances of hyperkalemia. So 4 weeks seems to be quite reasonable. So we call the patient back, and the patient is back in 4 weeks, and his GFR is still 45. His albuminuria is now down to 270, and serum potassium is 5.1. What should we do with his MRA dose? Should we stop this because it's now more than 5? And the answer is no. You keep going. You maintain the dose at 10 milligrams. You don't go up to 20. Why? Because the patient is having a higher potassium level, but you maintain the dose at 10 milligrams. And if you maintain the dose at 10 milligrams, you can call the patient back in about 3 months or 4 months and check a potassium again. You don't stop the drug because the potassium is more than 5. And let's go back to our tool that we have developed, the practice tool. And the patient now has USCR of 270 and GFR is 45. And the patient may be worried and say, Doc, I've lost some kidney function, I'm concerned. But look, USCR is also dropped to 270, and he has moved from a very high risk to a high risk. And if somebody sees these and says, oh, actually my risk has improved, and maybe I'm in a better place than where I was a few months ago, and that patient needs to be congratulated along with the doctor who's prescribing, because he didn't stop the drug when the potassium was 5.1, kept going. And if you keep going, you can derive benefit from it, because that's what we did in the FIGARO and FIDELIO trial. Now let's take an alternate scenario. What instead, our patient came to us using a different treatment regimen and worse kidney function. For example, the blood pressure is 168/70, eGFR is 30, USCR is 600, and serum potassium is 5.6. Patient is still on olmesartan and diltiazem and atorvastatin and chlorthalidone. The patient is on good dose of metformin, and the question is, what should we do? Well, let's go back to our worksheet and ask the question, what should we do? The patient has a GFR of 30 and potassium is 5.6. Should we be still using the drug? And the answer is no. The potassium is now more than 5.5. The patient was on 10 milligrams of the drug. You have to withhold the drug and consider restarting 10 milligrams once daily when the potassium is less than 5. For example, you can call this patient back in 4 weeks and say, okay, if the potassium is lower, less than 5, then potentially you can start the drug. But for now, because the potassium is 5.6, we're supposed to be withholding the drug. So what adjustments should you make to the medication regimen in this patient? There are several options. For example, you can discontinue metformin. You can make a strong case for it because the patient has a GFR of less than 30, and metformin is associated with lactic acidosis and accumulation, especially when patients go in the hospital for cardiac catheterization and have AKI. Metformin can play havoc, and typically a lot of physicians would discontinue metformin at this level of GFR. We can potentially reduce olmesartan dose. The olmesartan dose is not high, it's only 40 milligrams. But if you reduce the dose, it might mitigate the serum potassium level. And you might actually consider discontinuing olmesartan because of hyperkalemia. The question is phenerone going to work in the absence of olmesartan? We did not do that in clinical trials. We did not discontinue ACE and ARB in preference to phenerone in the clinical trial. So that's not what the recommendations would be. Could we increase chlorthalidone dose? Well, chlorthalidone was used in 25 milligrams once a day. The patient is not on a loop diuretic. You can potentially increase chlorthalidone dose. The advantage could be that potassium excretion may be enhanced and hyperkalemia may resolve more rapidly. You can potentially add a loop diuretic. I probably would avoid using a loop diuretic in the face of chlorthalidone, because if you do that, you're probably going to have more acute kidney injury. I'd rather increase the dose of chlorthalidone, which might facilitate potassium removal instead of adding a loop diuretic. And adding phenerone is not an option because the potassium now is 5.6. 5.6 potassium is not a good idea to use phenerone. So those would be the algorithms that some physicians might use, that we can go back to and ask ourselves the question, what should we be doing next if the patient has not responded or developed something that we don't have an answer to? And here are the various places you can go to: the AAKP, the ANA, the CKD initiative from CDC, NIDDK, National Kidney Foundation. Lots of resources for patients and healthcare professionals where a lot of information is available. There are many obstacles that can contribute to poor outcomes in patients with diabetes, and it takes a village to take care of these patients with type 2 diabetes and chronic kidney disease. These are incredibly complex patients because not only do they have diabetes and need for glycemia control, but they also have kidney disease. They also have a lot of cardiovascular disease. These are people who might have limited resources. They might have limited means to afford their care. And it's really important that there has to be a coordinated care in taking care of these patients. There are other important members of the care team, for example, diabetes educators, nephrology nurse educators, who play a critical role. Particularly when the GFR is low, they need education on how the renal replacement therapy would be coordinated. So it simply takes a village to take care of these patients. In closing, the standard of care for diabetes, kidney disease has changed significantly since the 2020 KDIGO guidelines, and which are somewhat already outdated. Since the publication of FIDELIO and FIGARO, we acknowledge that phenerone reduces the risk of progression of kidney disease as well as cardiovascular disease in patients with type 2 diabetes and CKD. It is the state-of-the-art treatment in people with type 2 diabetes and chronic kidney disease. The practice tools that we talked about today hopefully will help you overcome some of the clinical inertia and better involve the multidisciplinary care of patients with CKD and type 2 diabetes. Thank you for your attention.
This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/JNH860. This activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals, Incorporated.